Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name's Marc Ryan. It's a pleasure to be hosting this podcast, and thanks to everyone for listening in. As I always do, I will start with sort of an overview of the Healthcare Labyrinth website at healthcarelabyrinth.com. We do a number of different things. Number one, we have a weekday daily news feed where I comb about 24 healthcare websites, get the most important news, put it in one place at the newsfeed tab at healthcarelabyrinth.com. And I have some summations and some commentary as well on those news articles. So that's at the newsfeed tab at healthcarelabyrinth.com. Number two, we publish 2 blogs a week. One series I'm doing is talking about my courageous daughter's decision to have brain surgery, and really tracing her journey of her brain surgery, comparing how her very strong health insurance basically ensures that she pays little, but what would it mean for somebody that's underinsured or uninsured, as well as she has a connection to the United Kingdom and is actually eligible for healthcare over there, given she was a student and is now on a postgraduate visa, and why we chose to have her brain surgery in America versus the UK. So at the blog tab at healthcarelabyrinth.com, 2 blogs a week, as well as look for the blog series about my courageous daughter is having brain surgery. And so far there's been about 3 parts. And lastly, we also have the podcast. Of course, you're listening to it here, but we do a podcast once a week, and it is available at the website, but also at leading podcast websites and applications. So check out healthcarelabyrinth.com, the Healthcare Labyrinth website, for all your needs. Also, you'll be able to find out how to buy my book, The Healthcare Labyrinth, at the site as well. Let's get to the topic of the week, and this comes from a few people asking if I could explain the STAR program in Medicare Advantage. And I actually did a blog on this back some months ago, and you can check out one of the first few blogs at the blog tab at healthcarelabyrinth.com. But I thought I would do sort of a podcast on the STAR measurement program, what it means, what it is, what it does, and things of that nature. So to really begin with, to give you the foundation, the STAR program obviously seeks to sort of evaluate the quality of each plan at the contract level, which could have a number of different plan designs, and it would largely, although it's not always true, that it would rate the quality of an MA sponsoring organization pretty much at each state, which is generally where you might see contract numbers, although you can see multiple contract numbers per state as well. But generally speaking, it's seeking to equate at the contract level a health plan's quality to the enrollees. There are somewhere around 42 measures currently, and that can go up or down year by year. There are also 9 domains, 5 in the Part C medical world and 4 in the Part D STAR world, drug world. And so these 9 domains are areas for people to look at to determine how the plan does in certain areas. But more importantly, I think there are 3, in my view, types of measures that are within this overall STAR program of about 42 measures right now. And so number 1, there are clinical measures, and clinical measures seek to sort of see how people are doing on clinical outcomes. It could be wellness and prevention, it could be disease states, or it could also be complex clinical measures related to events like hospitalization and follow-up care, which I'll talk a little more about in a minute. The second type of measure is called member satisfaction. This is done through what is known as the CAP survey, and it seeks to really determine what a member thinks about their health plan, their providers, and the care they're given. And last, the third type is operational measures, which basically seeks to assess how plans are doing in various parts of their operation. It could be customer service, it could be appeals and response time and things like that. So those are the three types of measures. So in sum, 42 measures, 9 domains, 3 types of measures: clinical, member satisfaction, and operational. In the end, plans are sort of rated in all of these measures. Hopefully, if you're a younger plan, there may not be enough data. But generally speaking, as long as you have enough enrollment and enough time in the program, you will be rated in all of these 42 measures. And each of those measures will get a score from 1 to 5. And then you sort of have an aggregate scoring. So each of the measures, again, have their own 1 through 5 rating, and outcomes are sort of clustered based on cut points about 1, 2, 3, or 4 or 5 star performance. So, results are clustered. You have cut points to determine the rating. And you then come up with each measure's rating. You then also have weights on various of these measures. Some weights are simply 1. Other weights could be 2 or 3 and even 4. And so your result is multiplied by your weight, and you roll all of this up and divide it out to really come up with an aggregate score for the plan. When you come up with an aggregate score, you can have half points. So you could end up, for example, at 3, 3.5, 4, 4.5, or even 2.5 if you're really not performing terribly well. And so you can have half points at the aggregate. And this ends up being your star score for a given year. These star scores are announced each October for the coming year. So in October 2023, you basically had your 2024 star rating announced. That is what people would see on the website to enroll during the open enrollment season that occurred in late 23 for 1/1/24. That rating, though, does not get calculated into rates, and I'll tell you more about rates in a minute, until a year later. So your October 24 rating was announced in October 23. People start seeing that rating during open enrollment. They see that pretty much throughout the enrollment period in 24. And then in 25, your 24 rating will factor into the rate setting process we'll get to in a couple of minutes. There are some other things that occur beyond even weighting within the star measurement for each measure. There is a index for measures that have a large number of dual eligibles, perhaps in a plan, and there are adjustments made there. There's also a disaster adjustment that may occur in a measure. So beyond the weights, you have these dual eligible and these disaster adjustments and some others that get factored into the rating before the entire roll-up. But that basically gives you a little bit of a view of how star measures are calculated and the types of measures out there. Now, I will tell you that star ratings are getting tougher over time, and we'll get a little more into recent results, but there's a brand new Tukey outlier adjustment, which also goes into the calculation of star scores. And this Tukey adjustment essentially takes outliers out at the bottom end of the scale and at the top end of the scale, performers, low performers, and high performers before the cut points and the clustering occurs. And this tends to hurt plans in general, especially at the top end, where these outliers are taken out and it means sort of tougher cut points and tougher clustering in between. Weighting is also changing, as I told you, more weights, for example, on member satisfaction, and that makes it harder for plans to achieve 4-star or greater, which is generally known as the quality plan ratings. And then also there are some brand new complex measures that have arrived and more that will arrive in the future. And as opposed to standard clinical measures where you're sort of looking at an individual and whether that individual was able to get a lab score and perform well on it, these complex measures are more related to events that occur, hospitalization, and what is the kind of care a person gets in follow-up. So there's a series of new measures within the clinical category that I call complex clinical. It's related to readmissions to the hospital for the same type of procedure or readmission within 30 days. There's also follow-up care for ED visits for individuals with multiple complex comorbidities. There's transitions of care and how plans are performing in about 4 categories in transitions of care. And then there's also medication reconciliation post-discharge from a hospital. So these complex measures really are much harder to achieve, and that's also creating issues in terms of achievement globally in the STAR measurement program. So that's a little bit about how life is getting a little bit tougher as well. What I'd like to turn to now is how does STAR quality really factor into the rate setting system? So there are 2 ways that your quality score, the better that it is, the more money you get, factor into rate setting. Well, first, not to get too complex, and I could do a whole podcast on this, but there's something called the rate rebate. And your rate rebate advantage is really determined by how well you score on stars in the aggregate. And so in terms of this rate rebate advantage, if your plan in the aggregate, the contract scores less than 3.5 stars, meaning 3-star and below, you only get to keep what is known as 50% of the rebate. If you score 3.5 or 4-star, you get to keep 65% of the rate rebate. And if you score 4.5 and 5-star, you get to keep 70% of the rate rebate. Well, what exactly is that rate rebate, and why is it important if lower score plans get as little as 50% and the highest scoring plans get as much as 70%? Well, when plans come in to bid each year, there is a county benchmark, and a maximum rate for Medicare Advantage is set based on that county benchmark. In some cases, it could be a regional benchmark, but generally it's a county benchmark in any of the counties in the country. And in essence, that is the maximum rate that a plan could get. That county benchmark could range from 95% of fee-for-service costs in the county up to 115%. But that county benchmark rate is the maximum amount that a plan could receive. Then below that line, there is another line sort of drawn that is the bid that a plan has to essentially cover the basic benefits of Medicare fee-for-service. So let's just, for an example, say that maximum benchmark in a given county is $1,000. And let's say because an MA plan is efficient, that the plan bids 70 cents on the dollar to basically furnish the traditional benefits of the program. Well, that leaves 30% or $300 difference between the maximum rate and the amount that the plan is bidding for traditional services. Well, again, if your star rating is somewhat low, 3 or less, you get to keep 50% of that $300 in your rate, and that must go out to members in added benefits. And I'll describe a little more about added benefits. The other 50% or $150 will go to Medicare as savings. And that's my proof that the Medicare Advantage program actually saves dollars. Obviously, if you're the highest scoring plan, you can get as much as 70%. So you would keep 70% of that $300 or $210, and just $90 would go back to Medicare and savings. So that rate rebate gives high performing plans a great advantage. They are being paid more, but the theory is that because they're quality plans, over time, better outcomes will occur, and perhaps we'll have cost reductions in the future through better monitoring and outcomes. And so that difference of somewhere around $60 goes to the plan, and that gives them an advantage in the market because $60 per member per month is a lot of money to spend on additional benefits in terms of the difference between the lower scoring plans and the higher scoring plans. So that's the first way that high quality plans are able to get an advantage in the market in the rate setting process. The second way is relatively simple. If you score 4-star or greater in the aggregate for your contract, you are given an extra 5% calculation in your rate because you achieve 4-star or greater. There is a percentage reduction applied to the quality bonus, just like in the rate rebate advantage. But let's try and sum all this up. In the case of high performing plans, we talked about them getting $210 between the county benchmark and the bid for fee-for-service benefits, and the low-performing plans getting $150. When it comes to the quality bonus for 4-star or greater, they are receiving, depending on the 65% or 70% discount, $32.50 to $35 additionally as well. So 60 plus $32.50 or $35 gets you to $92.50 to $95 more per member per month. I tend to just round that, and I always say that high performing plans are getting somewhere around $100 per member per month more than, say, lower performing plans. That $100 is an amazing additional leverage in the market for these high scoring plans. And basically what happens is plans seek out members. Members seek out the highest performing plans for two reasons. One, they get much better benefits because of that added $100 per member per month, for example. And number two, they also see quality ratings when they're searching for plans. And they always sort of want to be in higher rated quality plans as well. So that's our second area of focus, how the rate setting works and advantages highest performing plans. And again, I give CMS a lot of credit for creating what I believe is a complex but a really, really important quality bonus program. And it really does help drive quality out there. Let's talk a little bit now about stars of late, because this will be very important. So historically, we sort of saw a pretty good performance among plans. So not great, but pretty good. And so I'm going to go back to 2021 star ratings here because this was sort of prior to COVID. That 2020 rating was prior to COVID due to some lags. I would also tell you that when you get a rating, the results are based on history. In some cases, the measures may just be a year back. In other cases, it could be 2 years. In some cases, a result could be based on data that's 3 or more years old. And so it's a little bit historical, and that's why I say if we base what I'm going to say right now on 2021 ratings, that's because it really has data prior to COVID for the most part. So the average MAPD score in 2021 for STAR for MA was 4.06, so just above that the high quality STAR rating of 4. However, just 48.5, roughly 50% of all MA contracts achieve 4-star or greater. But what's important to note is that enrollment in these plans with 4-star or greater was about 76.8%. So almost 77%, more than 3/4 of all enrollees in 2021 enrolled in the highest rated plans. So that's why I say things are pretty good. In terms of five-star contracts in that year, there were about 21 contracts that achieved that perfect 5-star rating. So again, average score right above 4, about 50% of contracts achieved the high quality rating of 4-star or greater, and over 3/4 of all enrollees were in those 4-star or greater plans. I tend to really discount what happened in 2022 and to some degree 2023. And the reason that is because some of the measures were sort of suspended, the calculations were suspended due to COVID, and it artificially increased results during those years. And consequently, plans that generally never performed at that 4-star or greater rating tended to achieve those ratings. They beefed up their benefits, and you sort of had a surge of people that were in these 4-star or greater plans. For example, in one year during COVID, in the 2022 star rating, almost 90% of people were in 4-star or greater plans, and almost 70% of contracts were 4-star or greater. Well, it was very artificial due to the suspension of measurement and things like that, and flexibilities in STAR during 2022 into some degree 2023. So I'm going to jump to 2024 here and show that there is a distinct erosion of STAR performance since pre-COVID or 2021. So in 2024, the average STAR rating slipped from 4.06 in 21 to 4.04 in 2024. More importantly, the number of contracts that achieve 4-star or greater dropped from 48.5% down to 42%. That's just a marked decrease and very troubling. Even enrollment of enrollees in those plans with 4-star or greater dropped fairly significantly from that 76.8% in 2021 down to 73.7% in 2024. So again, big cause of concern that the average score is dropping pre-COVID to post-COVID. The percentage of contracts achieving 4-star or greater dropped dramatically, and even enrollment in plans has enrollment of eligibles in these 4-star or greater plans has dropped. So a bit troubling. And again, I point back to what I said earlier. There's this brand new Tukey formula that takes away sort of the excesses in terms of low performers and high performers. There's differences in weighting, and there's also some complex measures coming in which are creating problems. And again, the COVID flexibilities were no longer there as a fourth reason for erosion of STAR performance pre-COVID versus post-COVID. So that is just a quick wrap up of STARs of late and why we're a little bit worried about some of the achievement here. So let's talk a little bit about what does the future hold. Well, number one, as we've talked about, plans really need to begin to focus on quality achievement, because that extra rough $100 per member per month that high scoring plans get compared to low scoring plans will mean the difference in surviving in the market or not. And I would say just in general, more than 50%, almost 60% of plans now are struggling to get to that 4-star or greater high achievement. And I would also note that it's not just the smaller, newer plans. We are seeing long tenured plans, as well as even some of the largest plans, really struggle. On the big player front, United and Humana seem to have locked in good star performance over time, although they've even had some volatility of late. But some of the other national players have had trouble in 2023 or 24, or frankly, both years. And so this is not just a problem for smaller, less technical plans. It also impacts the longest tenured, biggest plans out there. In many ways, the COVID allowances have led many plans to become very complacent in this really key revenue and competitive advantage area. So they really have to refocus here and make investments in new technology, clean and timely data, and really expertise internally to hone a consistent and high performing program. While many plans also think about the immediacy of moving items, I would also note that we talked about the long time it takes to impact and the fact that data and measurement goes back in time. You need to sort of strategically look at how to move things in the short term, drive those, but also recognize the long tail of STAR and again, build this consistent high performing program I talked about. I would also note that member satisfaction scores are tending to really cost plans high achievement. Really, there's poor performance across everything, but if you have to single out one area, member satisfaction is sort of a key area. And that's going to take investments not only in member satisfaction, but also provider satisfaction, because oftentimes providers impact how members feel about their health plan and how they respond on member satisfaction surveys. What are some potential regulatory changes in the STAR area as well? Well, beyond the changes in weighting and new scores and things like that, we have MedPAC, the congressional policy arm, and other advocates and critics calling for major changes in STAR itself. On the funding front, some are calling for STAR to be what is known as budget neutral, where this quality achievement money will no longer be additive to federal dollars as it is today, but be taken out of the main rate setting dollars, so that there is savings to the budget, and that it means that plans will pay even more attention to STAR achievement. I'm not in favor of this idea. I think it's much too early to do something like that. I think Congress has made a deliberate decision to try to find ways to incent and drive quality. So I believe STAR dollars should still be additive. On the technical front, MedPAC and some others are also looking to refine the program in a couple of different ways. Number one, they are looking for plans to be rated more at the local level versus the contract level, and finding ways to really determine quality at a very local level rather than at a statewide, as an example, contract level. They also would love to have plans be rated against peer groups, looking at the demographics and the characteristics of a health plan and have that plan be rated against their peer groups. I would also note that many are also calling for separate special needs plan scores, STAR scores, because they believe that maybe dual eligibles are not being served terribly well, and that a quality rating system specific to dual eligibles or to SNP contracts should be set up. Well, I will note that a recent regulation by CMS begins us in that direction by giving states permission to say that they would like SNPs to be broken out in separate contracts with state Medicaid agencies and therefore separate contracts with CMS, and that over time we could see separate special needs plan scores occurring. And that creates some danger, obviously, for plans as well. With that, we'll end this episode. We hope you enjoyed learning a little more about MA stars. We hope you visit healthcarelabyrinth.com for our news feed, our blog, and our podcast. And we'll see you next time on the next Healthcare Labyrinth podcast. Take care.